Hi, everyone. Welcome to our webinar today. I'm Ren Keeper, and I'll be hosting and getting us started in just a couple minutes. It's 12 on the nose, and so what we'll do is give folks another minute or two to join us, and then we will get started. So we're going to get started here. As I mentioned a minute ago, I'm Ren Keeper, Managing Partner at Cardinal Consulting Group, and we're pleased to have you join us for our webinar today. We're intending to cover a few key topics as health systems and physician organizations start to look to the future and rebuild volumes, make up for lost time in value-based payment arrangements, and take the most advantage of relief programs and regulatory flexibility to make the most of the remainder of 2020 and set up themselves for financial success going into 2021. First, I'll give a quick introduction to our speakers today. We're excited to have partnered with Arent Fox as well as the Marblehead Group to have some excellent speakers join our webinar here this afternoon. The first from Arent Fox is Tom Jeffrey, a partner with the firm representing hospitals, health systems, and other providers, as well as managed care organizations across facility development, mergers and acquisitions, payer contracting, fraud and abuse, and other areas. So Tom will speak today on regulatory flexibility as well as relief program funds that may be still available to assist healthcare organizations and offer his insight on the remainder of 2020 going into 2021. Also joining us from the Marblehead Group is Lisa Soroka, principal with the firm, and she's an experienced healthcare consultant with over 20 years of experience in virtually every aspect of hospital and physician operations and management. She assists clients in obtaining optimal business and operational performance, primarily in frontline operations, but as well as in fiscal management and financial planning, as well as sits often for her clients at the intersection of payers and providers to ensure optimal outcomes. And lastly, myself, I have 15 years of experience as a healthcare advisor, working specifically in payer-provider relationships with a focus on value-based payment. And at Cardinal Consulting Group, I focus in on value-based payment strategy and implementation. So I'll just, with that, advance into a very high-level overview of where we are today. Many of you joining us are on the front lines of the COVID-19 crisis and have been dealing with this slide you see here since the beginning part of the year. We've just surpassed 2 million cases and about 113,000 deaths. So, of course, lots of red circles you see here that really represent the headlines that we hear every day in national media. Many of the organizations we're working with are really in the epicenter of these hotspot areas, having a fair amount of our book of business, all three of us, on each coast. So continuing on where we are today, a number of healthcare organizations realized that the ground had shifted underneath them in the early part of this year, March going into April in particular, with a rapid shift in roles. All of a sudden, specialists might have changed their guidelines for appropriateness of care. Primary care providers suddenly became COVID-19 triage. all of a sudden, hospital beds had special needs. So allocation of hospital resources became increasingly important in it almost overnight. There was a rapid shift in payer mix as the job market started to be impacted. And of course, their behavioral health issues and increased social needs with the changing economic landscape. A lot of what we'll focus on today as we look to the future is how to ameliorate the disruptions that we saw very dramatically hit the healthcare enterprise going into the second quarter. Specifically, everyone across the board in all sectors have experienced a dramatic drop in volumes due in part to patient reluctance, concerns about inadvertent exposure and thus leading to closures, as well as mandates, specifically regulatory action around the cancellation of elective procedures in the inpatient setting. So of course, there's a dramatic financial impact there as a reduction of that volume, as a result of the reduction of that volume. And technology and telehealth has played a huge part in staying connected with the patients who may not have been able to feel comfortable enough or couldn't come in for elective procedures. And we'll talk a bit about that. But of course, technology and telehealth can only go so far. And so it's not a complete counteractive impact to the reductions in volume. Last but not least, of course, we've all been dealing with staffing and supply inadequacies. Again, all sectors in the healthcare vertical have dealt with this. And I don't need to probably induce PTSD for folks who have been able to overcome this on the phone. But of course, PPE shortage continues to be an issue that we see nationally, especially in areas that are starting to see an uptick in new daily cases. Concerns are arising about supply shortages coming back into the foreground. So with that, I'm going to turn it over to Tom to talk a bit about financial impact and what to do right now from his perspective.
Thanks, Ren. Of course, when this was all unfolding in early March, everybody began to look at starting to take measures and initiatives to try to get ahead of this. And Congress passed a number of relief programs, the Payroll Protection Program, the Medicare Accelerated Payment Program was, which had been there. The rules were opened up so that hospitals would automatically get some accelerated payments. There were special codes added to provide for specific COVID-19 testing and the like. The Provider Relief Fund was put together, and then there were a lot of state programs designed to assist hospitals and other providers to get ready. The challenge then has been and continues to be to be prepared and to try to mitigate the financial impact is to obviously track all these programs, but some of them need to be applied for. And so it's important to sort of stay up to date and current. We'll see what happens with the HEROES Act, which is, if you will, COVID legislation part 3, but that's still pending in Congress, and it doesn't look like that's going to be coming out anytime soon. I think the other thing that at least most of my clients and people I know in the industry have jumped on are really looking at their operations and what appropriate operational changes are necessary. And there are legal implications for this because obviously you want to mitigate not only legal liability, but just liability for or responsibility for patient safety, employee safety. And so doing additional steps for infection control and limiting the who comes into the hospital facility and testing of employees and that type of thing are all part of the challenge, but part of the changes that people have needed to take immediate action on. In addition to which, there are certain reporting requirements to the state, or often that go up to the federal government, to the CDC. And again, now we've got new processes that you need to take into account for. But there is also opportunity here. The opportunity is in new business and services. So this is not just a period of circling the wagons to prepare for COVID, but to maybe be proactive in what business and services could be added that might help or work with the bottom line, if not immediately, maybe long term. And telehealth, I think, being probably one of the bigger opportunities in services that hospitals and other providers have expanded to. The other important thing to do right now is to document all transactions. And what I mean by that is the financial transactions you have under the guidelines for the accelerated payments and the provider relief fund. You're going to need to track COVID-related expenses and separate those out from everyday expenses. And that is not going to be something that can be done easily retrospectively. So it may mean opening up new line items or sub-line items so that those expenses and revenues to some extent could be tracked accordingly. You want to go to the next slide, Ren? So the good news, I think, in all of this is that in addition to providing some funding mechanisms and the opportunity to explore new business, there was some regulatory flexibility that I think provides, again, a lot of opportunity to perhaps change operations or expand certain services that may have been limited because of regulatory restrictions. The classic example of the Medicare 1135 waiver, Medicaid, is that it provides for expansion of the use of telehealth for visits that would not have been authorized or within the program before. The Stark and anti-kickback laws have limited exceptions. They had indicated that they would not, it's not really exception, that they would not enforce those provisions if necessary because of COVID-related circumstances. So the example would be, let's say the hospital owns a medical office building. The physicians have had a big hit to their income as well, particularly maybe the surgeons and the orthopedic folks. And they come and say, you know, we're not going to be able to meet rent, or we need some relief here. To the extent that that's specifically tied to COVID, to their reduction in business. And there's some flexibility there then to say, okay, well, we will not collect rent for the next few months, or we'll tack it on to the end. But you can't go wild with these particular waivers. I think there's still an expectation that you'll collect from the physicians, or collect something from the physicians when things get better. So again, you need to talk with your advisors, legal counsel, on how to implement and do that. One of the other things that they've indicated is appropriate or incentive payments. They realize that to get some physicians or certain providers in, particularly in a dangerous situation where they're going to potentially have higher exposure, is to pay them sort of combat pay, if you will, and there's some flexibility there. Flexibility in scope of practice, you know, in terms of nurses and nurse practitioners being able to provide more care, expanded care, than they otherwise would be allowed to. That's probably more on the state level, as well as licensure on the state level. Again, providing some flexibility, perhaps in terms of using areas that had not been used for patient care or may have been abandoned for use of patient care, so that you have the appropriate capacity here in California, nurse-patient staffing ratios. So there is some flexibility that I think helps out during this time. Of course, you got to be careful that this too shall pass, and you got to be prepared to sort of switch back when the state of emergency that has provided for all these waivers is rescinded or concluded. I think, Lisa, you're next. Ren.
I am.
Actually,
Thanks,
Ren.
Tom. So on the screen, you'll see a long but not exhaustive list of areas of impact relative to revenue in the healthcare enterprise, hospitals, health systems, physician organizations, clinics, even public agencies, all participate in some form of the revenue sources you see on the screen. And many, if not all, would have some level of impact from the crisis. What we're going to do now is serve up a poll, some of the more common revenue sources, and take a moment, if you would, to just vote on which you think are going to have the some long-term instability, or perhaps vote on the one that you're most worried about in the long term as you look to the future. Considering the last part of 2020 going into 2021, there's likely to be long-term impact. So there should be a poll on your screen in the sidebar. So go ahead and vote. What we tried to do here is just tee up a bit about what we're going to talk about on the next couple of slides on how to innovate your current operations and services, either by leveraging some of the waivers that Tom just mentioned, or by maybe rethinking or reimagining how you interact with your patient population, and really get to a place where you have a bit of a game plan going into the latter part of the year to try to rebuild some patient volumes, address pent-up demand, make right on some of the value-based payment arrangements, including pay for performance and other kinds of VBP style incentives, so that the rest of the year is more of a rebuilding time and leads to a more successful 2021 in light of everything that's happened with the crisis. So it looks like we've got a fairly even split across fee-for-service, Medicare program or incentive payments, and risk-bearing models. So with that, Lisa, I'm going to turn it over to you to start down the road of this conversation we'd like to have about innovations, specifically related to operations and services.
Okay, I'm going to take over with the tree slide here. And really what I want to use and talk about are examples and where you need to keep going. I'm not at all underestimating that you've obviously had to deal significantly with operational changes, and you've had to be creative, you've had to be quick, you've had to be incredibly responsive. So, for instance, in terms of the crisis related services, is how have you dealt with having to have tests, sites for testing, sites for triage, and then treatment, and how have you had to repurpose your space for the patients that you have on site? And also, how have you had to repurpose for your folks moving into telehealth and taking advantage of the telehealth opportunities? Is how have you had to reconfigure for that? And the fact that I think what's most critical in that we've all discussed is you have to be able to deal with both your tech savvy and your non-tech savvy patients. And this can span, probably doesn't span the younger patients as much, but obviously, and it's not just the older patients. It's across, continuums. And when you look at the differences also in your commercial versus your Medicaid, Medi-Cal populations, who has access to the software, the hardware, who has iPads, who has, et cetera. I mean, this one clinic that we've worked with, we're ingenious, I think, in terms of having to do telehealth visits. The patients didn't have the technology in their home to adapt it, so they drove to the office, and like picking up your groceries or like picking up your to-go orders, one of the staff came out with an iPad, handed the iPad to the patient, had, the sanitized iPad, and the patient felt very comforted that they, in this case, it was a woman, she saw her physician, who's in the building, but she didn't have to go in. She could remain very comfortably in her car and do it. And it was a very easy solution, for this particular patient. You may not have to do that for another patient. So you can continue with telehealth and you can do it from the home, or you can have a caregiver, helping out too. So lots of different innovative and unique ways to look at things. Critical in terms of space design, how are you going to use it most efficiently and effectively, and how are you going to reconfigure it so that your patients can be there and be safe, and be there? And how can you accommodate? How many can you accommodate? Where do you accommodate? Is it like with one group that I was working with, they were taking all the temperatures, they were keeping the 6-foot distancing, they were doing it in the hallway. The reason they were able to do that is in their MOB, a lot of the offices weren't open. Now that it's getting more crowded, this particular office had to completely reconfigure how they were doing this, for their patients. And then also, how are you using community resources? So how are you working with them also in your whole space design? Are they integrated or not? The patient communication, I think what is most critical about this is you have to communicate them. Be the source of knowledge for your patients. It's patients need to know, are they safe? You need to assure them. You need to tell them what's happening with the crisis, what's going on. They're looking to you for this. And even to the point of, some folks I'm working with, it's 2 times a week minimum that they're looking at communicating with their patients. A lot of organizations are communicating daily because they, again, want to be the source, not just for their patients, for their community. And so in terms of where you are and worrying about your business, as your business has tanked, and as one colleague of mine has said to me, we're now trying to deal with the financial ruin that this has wrought to us. What can you do? And frankly, I put it bluntly, how do you get your slice of the pie? I mean, the pie is still there. It's changed in a lot of ways, but you need to get your fair share of it. So you need to be really thinking about how you're going to get not just your business back, and then how you're going to account for the business that isn't going to come back, and what's going to change, and what's the landscape going to look like, but how you're going to get different kinds of business. So with that, let's move to the next slide, Ren. And so really, again, you've been dealing with this. You all have. But big concern around the first line of, shortages. It's not just that the patients have had difficulties throughout this. I don't think we can underestimate what it's been like for providers, and what it's been like to be a frontline provider, and what it's been like to be any of these providers. So what we need to do is recognize that there's going to be a huge increase in behavioral needs services, not just for patients. This is also for the physicians and for the staff and all the ancillary staff. What's going to happen with provider attrition? How are you going to deal with it? You're going to have a certain number of providers who are going to say, I just can't do this anymore. It has changed too much. I'm retiring early. Or you're dealing with a whole lot of your staff saying, I'm going to switch fields. I just want to get out of healthcare. I don't think I want to continue in healthcare. And we know that all the frontline workers have been so heroic and so, but it's taken a lot out of them to do it. So what are you going to do to replace that? You've got to have a plan in place, because pent up demand and demand period is going to come back for services. And then figure out, and I'll talk about pent up demand later, but you're now treating everybody as if they have COVID. And so basically, again, I'm sure for those of you on the line, you've all come up with different ways, to do this. But now we have to deal with this continuing. It's not going away anytime soon. And so how do we figure out how to do that? And then, not lastly, but you've got your administrative staffs backing up the clinical care. And frankly, where are you going to put them? At this point, maybe the space for the billers and collectors are too small, or maybe the space for the managed care folks is, they can't maybe stay in the hospital anymore where they've been, or even in the office building where they've been. How many of them are you going to let work still at home? I mean, we've seen an amazing change in ability to work at home, but how are you going to set up your schedules? Like one group we're working with now is figuring out how in their administrative area, you're still going to have some sort of patient contact, like when you're admitting a patient or registering a patient or doing something. How are you going to do it? Are you going to do the pre-registration where the patient waits out in the car and, just comes in when the physician's ready or the MA's ready? Or do you have enough space in your place to safely space them? How are you going to assure the patients that they're going to get well taken care of? What sort of new barriers do you have to put up in terms of productive barriers, et cetera? So think about that, all those different issues. And with that, I'm going to turn it over to Ren. Next slide.
Sure. So I'll just briefly touch on some lessons learned in the context of recovery and going into a new period where patient volumes may be aggressively pursued in order to offset some of the drops that we saw in the first part of the year. As the country continues to reopen economically, there's obviously going to be resurge, which I consider a resurgence to be something more broad geographically, versus a hotspot, which could be localized, even as a region within a city or a component, a borough, let's say in New York City, versus a resurge might be something that's, all of downstate. So as you think about being in a leadership position in a healthcare delivery organization, these two concepts of research and hotspots are going to be top of mind as the economy continues to allow everyone to interact with each other, obviously, which is going to spur an increase in cases. And of course, we've already seen that. So on the research side, really taking what Lisa was just talking about relative to space planning and COVID, non-COVID care delivery, and developing a proactive strategy so that as the case rates for your service area start to change, either going up or going down, or hopefully going down, you're able to actually have a fairly agile strategy that you can deploy in a matter of hours on how to deal with an oncoming resurge, which means that an area that might have been deemed, non-COVID care delivery can very rapidly, perhaps overnight, be converted back to a COVID care delivery area, so that your facility or your office is well prepared for an uptick in care delivery relative to that research. The other thing that's important is patient education. Lisa mentioned being a resource for the patient population, being a source of truth relative to cases in your region or your service area. So allowing that patient communication to flow kind of irrespective of other communication channels, so that the patients know what to do in the instance that a research starts to become apparent, so that then the patients will know who, if there's a hotline that they can call to get access to the current testing sites. As the economy starts to reopen, some testing sites need to go back to their regular business as usual. We've seen a lot of shuttered businesses repurpose as testing sites, as an example. So where and how testing gets done is going to change in the latter part of the year, and being a source of truth for that might help the ability for you as an organization to deliver care when if and when a research happens in your service area. And then, of course, get tied to the strategy planning, really getting a good handle on reliable leading indicators. Public health has started to get more rapid in their cycles of reporting. A lot of that had to be built in order to get government approval for reopening. So kind of tapping into those leading indicators that are used for more broad economic monitoring are relevant to your delivery organization as you keep an eye on the service areas and the case rates within your service area. And then hotspotting, could be, thought of as a more block by block or, section by section of a city where there really is a high concentration of cases due to some localized circumstance. And really getting a pulse on the organizations that serve the homeless communities, as an example, or areas where there are going to be expected high density gatherings. We know that political activity is going to start to resume nationally going into the election. And so getting ahead of where there is known to be highly concentrated populations for an event at scale, those are leading indicators that could potentially lead to a hotspot. So if there's a way to keep tabs on that, and then be ready for a quick uptick in cases that could then result in a rush on services. That's the kind of thing that, as a healthcare leader, you'd be thinking about relative to ensuring that capacity is rapidly available. Even if that might not impact, let's say, an entire health system, it might impact one facility of a health system, given the highly localized nature of the hotspot. Of course, mitigation strategies for hotspots include getting care delivery into that community. So if a hotspot includes, 2 or 3 apartment complexes in a highly dense metropolitan area, there could be testing deployed right there within the environment to help to limit movement of the folks who have tested positive, and get contact tracing started in coordination with your city or regional governments, so that there's a bit of a health system and care delivery coordination with the other efforts that will be deployed to manage to a hotspot. Of course, the indicators for hotspots are a bit different than a more broad research. Really on the street coordination, again, with agencies that deal with the homeless population or folks who live in a highly dense, perhaps low income area, are going to be important. And when I say local level leading indicators, that could be, an FQHC that's actually working on the street in a particular area, that can get a sense of a truly localized hotspot, again, in contrast to a more regional research. I think I'm turning it back to Lisa, talking a bit about considerations for recovery, specifically relative to partners.
Okay, let's start on the left-hand part of the slide, built today. I think I'm going to emphasize the increased need for behavioral health and how this might be shifting the care paradigm a little, because otherwise healthy individuals who have gone through this. And again, this isn't just your patients, it's also really your providers and staff. You've got to really think about that. So you've got to think about, how are you going to include behavioral health needs, increased behavioral health needs in your care models? And then you need to understand really clearly what's happened with those patients who have delayed their necessary care. How has it impacted them? Those patients probably don't understand. They're just so fearful of coming into a facility that they've put it off. And so you need to know within your own population, patient population, what has happened. Yeah, who's delayed care, what kind of care. And in the course of all this, you have got to, I'm going to stress, you have to address patient fears about actually coming into a facility. And then you have to really identify how you can make the patient comfortable. The patients are looking for that. They really are looking for you to solve these concerns and address these concerns and solve these issues and really, decrease their fears. So in terms of going down the slide, select winners, you really have to do your analysis here. You really have to understand of your program services, offerings, what can come back quicker? What can you make mobile faster? What can you make money on? I mean, that's an important, piece of it. And what makes sense, in terms of bringing back your services, and in what order, what combination, what makes sense financially and operationally. And then I think that you need to do is you've got to listen closely to your patients, like I said, and really understand and identify their ongoing needs and figure out how to address those needs. And frankly, it just doesn't matter if you think you can offer stuff. If it's irrelevant to the patients, what difference does it make? I mean, really what you need to do is you need to offer what they need. Go up to your future state. We're in a really tough time now. We have to figure out how to pivot. We have to figure out, how we're going to survive in the future. Ren just talked about the next surge, the next wave. I mean, a lot is happening there as states are opening up and as we've had these huge, huge mass gatherings, unfortunately cases are going up and deaths are going up too. Think about what you did well during all this. You guys scrambled to make this happen during this whole, what worked well? What can you keep? What will keep working in the future? Also, though, learn from your mistakes. I mean, I think every successful person has always talked about the fact that you learn best from your mistakes. And then identify what you should have done differently and figure out how to do it differently. Now that you have some time to reflect on it, figure out a better path. And really what you're doing is you're preparing financially, operationally, and behaviorally too. I think those three are all very intertwined. So what do your future partnerships look like? I mean, really think about it. I mean, we could talk about this as what does your future ecosystem look like? What does your community look like? What does your healthcare universe, look like? And really think about and identifying, exploring who you want your future partners to be. And please, in the midst of this, do not forget or leave out your community partners, because they are critical if we are to continue, particularly in value-based medicine, and in terms of working under high-quality standards. I think we've all realized by now how important the community-based partners are at getting patients into care, working with patients, dealing with issues. And then a thought: have you talked about how you're going to co-manage your patients with if you're a health system or a hospital, or how are you going to do it with your physicians? How are you going to bring costs down? Cost reduction is going to be huge in this scenario. And then I think the last thing is really think about, fee for service. Fee for service has been real tough for us right now. The move to value-based is probably going to still happen. And how are you going to be able to handle that? Next slide, please. I said I'd talk about pent-up demand. Again, patients have deferred care. They just address their fears, move on, with that. And the other, I read a really good study, actually poll recently, out of Revive, which patients don't understand the difference between inpatient and outpatient care in terms of where COVID exists. They think it's everywhere. So you need to talk to them about how you're addressing this in both those settings to get rid of their fear. Rescreening. A lot of patients, the top right box, they've deferred care. We know that. Get in touch with them. Again, at the top of their list is assure their safety, that they are safe. And actually, another poll recently showed that patients at this point are paralyzed with fear in terms of returning to offices, to care sites. They will switch providers if they feel they're safer in another provider, including surgeries. They'll leave a pre-scheduled surgery and that surgeon to go somewhere else if they feel it's a safer place for them. Catching up. Get in touch with your patients. I already talked about this. And then figure out how to nudge them back in. But important, be understanding of their other issues they're dealing with. They're dealing with transportation issues. They're dealing with childcare issues. They're dealing with caregiver issues. All of this has fallen and risen during this time. So in terms of getting ahead, one point I want to make here that I think overrides everything is we're going to see, and already are seeing, a major shift in commercial coverage, payer coverage. Commercial patients are losing their insurance. They're going over to Medicaid or Medi-Cal. And how are they going to deal with it? Some of these patients are patients who in their life never receive public assistance. They have no idea how to operate within a Medicaid population. Who are you going to partner with to help you do that if you're a commercial, mainly commercial provider? But how are you going to help the patients, again, navigate through it? Okay, next slide.
Briefly here on value-based payment, and organizations nationally have stratified themselves into various value-based payment arrangements. Moving from sticking with fee-for-service arrangements and simply entering into pay-for-performance deals, all the way up through, commonly here in California and some other parts of the country, full delegated programs that include risk transfer. And so, each value-based payment arrangement is going to have some considerations as you think about just how decimated your 2020 budget is, and in preparation for 2021 business planning. So let's say you're in a pay-for-performance deal where likely you've had a significant drop in volumes that has resulted in a significant drop in revenue compared to budget. Pay-for-performance, I like to say, should never be a reliable revenue when you look at a health system, but I know that many organizations do push to consider P4P incentive payments from plans as part of top-line revenue in a budget setting. So if you haven't already, revisit your P4P revenue expectations for 2020. It's the drop in volumes. It's likely that a lot of those folks that Lisa just mentioned who have chosen to defer care or have dropped out of care plan management or care management interactions are going to be absent from your numerators for these P4P metrics. And so you really have to take a look at how you might be able to leverage pent-up demand if your patients start to flood back to office-based settings to get as much of the members moved from denominator to numerator for these P4P measures and actually make up some time to meet some of these incentives so that you can rely on those dollars. But more than likely, more than a handful of your revenue expectations for P4P measures are going to be missed this year. So that might mean a tough conversation with your insurance plan partners, your health plan partners about exclusion criteria for denominators, things that might allow you to actually meet your metric and realize at least a percentage of those dollars. We have heard some national plans have been proactively outreaching to organizations that are likely to miss their P for P targets, and negotiate with them about exclusion criteria for their denominators. For shared savings or shared losses, those of you in an MSSP ACO or some other ACO arrangement, on the commercial side even, if there's the ability for you to negotiate, downside risk terms, do so now, especially if you're in a shared losses arrangement. Your TCOC, your total cost of care, your TCOC is very much going to be adversely impacted. Now, Medicare's made some exemptions to benchmarking. They've, in bundled payment arrangements, offered for the exclusion of COVID-related discharges. So there is some flexibility already starting on the Medicare side. On the commercial side, it's pretty varied from what we've seen. And so to the extent that you feel comfortable picking up the phone and having a conversation with your plan partners about shared losses, definitely do so. On the shared savings side, again, with P for P revenue, I like to advise my clients not to include, or definitely not 100%, but not include even a certain percentage of shared savings as an expected revenue source. So there's so many variables that go into earning that shared savings payment. So, as far as I'm concerned, eliminate any shared savings revenue that you had in your 2020 budget, unless you have a really good reason to rely on those dollars. But as relative to shared losses, as you start to think about pent-up demand and how volumes may come back, there may be an impact on TCOC adversely in Q3, Q4, which might be compounding to your COVID-related expenditures. Obviously, the COVID cases are higher acuity, require more resources. Many are ICU cases, and those discharges have an impact on TCOC unless they've been exempted in the cases like Medicare I just mentioned. So there's certainly an opportunity to work within the ACO arrangements that you might have that involve shared savings, shared losses deals or terms, and getting ahead of that, if you haven't already, is going to be important to get a better look at what the rest of the year is going to do relative to budget. Now, if you're in a risk transfer deal where you're actually taking on some kind of risk with your payers, it includes a prospective payment for either professional services, institutional services, or both, you actually might be in a position to have a relatively little impact on your total cost of care budget. So if you have some of those deals and you haven't already tried to take a best guess at impact on COVID-19 on TCOC, do so now. Because you may be able to actually stay relatively close to budget, even with the increased expenditures on the COVID side, because of the reduction in utilization for voluntary or elective surgeries on the facility side, or you can offset a drop in expenses related to offices. If you are at risk in an office-based setting and those offices have been closed, it's likely you're still receiving a good portion of their professional fees in your PMPM. So keeping an eye on that budget for the remainder of the year may allow you to come out, if not break even, perhaps with a negligible loss on your budget. And then as you think about cost containment, Lisa mentioned co-management, which is, a possible strategy. There are other ways, that you can look at cost containment and reducing your expenses. Again, that could help mitigate some of the COVID-19 expense impact on your managed care risk transfer books of business. So with that, I think I'm going to take a breath and turn it over to Tom to talk a bit about some of the legal considerations that are in light of reopening.
Thank you, Ren. And as indicated earlier, this too shall end, and so we do need to consider some things or be aware of some things as we start planning towards the reopening. Again, we talked earlier about the funding that's in place. I think that there are going to be some additional reopening assistance funding. We talked a little bit about the HEROES Acts, but there were, I think, are going to be specific grants and more targeted funding in supporting hospitals and certain other institutional type of providers. The other thing I think to look at is additional services, and again, not to harp too much on it, I think the telehealth has taken a huge boost in having acceptance both by the regulators and the payers to be something to go forward, and again, that's maybe a good place to be. Program flexibility, we talked about waivers, those will come to an end, we know that. I think it's important to sort of keep an eye out on whether some of those changes become either more permanent or extended. So certainly you need to keep an eye on when those waivers will come to an end, and as a result, what, if any, flexibility after that will allow you to continue to operate in some ways that will save money during this sort of revamp or reopening period. Very important to keep an eye on overall liquidity. The economic downturn is sort of another component of the whole COVID-19 crisis, and creditors, I think, are going to be looking very carefully as to whether you have reached a point or close to a point of insolvency. And so it's particularly important that your board of directors understand their obligation and to be aware that as funding stops, as funding shifts, if there's a liquidity issue that needs to be addressed head on and early and not later. And again, a lot of the funds that have been received are subject to audit or reporting requirements. And again, you need to be prepared for that because you certainly don't want to have to give back money, or at least have to give it back when you didn't think you had to. So all important legal implications to keep an eye out on. Strategic alliances, I think, are going to continue to be important, particularly as they relate to, providing kind of community care in an efficient and effective way. I think one of the benefits that comes out of this is increased awareness of public health and the ability of public health to come in and sort of reach alliances with various types of providers to provide appropriate care. Community-based organizations, I think, again, are also part of that, whether those be community family clinics or other social agencies, social welfare agencies. Again, I think these are going to provide a little more holistic approach to providing healthcare services post-COVID. Ren already talked about the importance of health plans. They can be your enemy, but they can also be your friend, and some of the considerations on short-term and long-term contracts or accommodations that you might want to ask for them. And we also talked about community clinics. So I think there is hopefully a rainbow in our future, and I wish everybody a lot of well as they sort of continue to wade through this and come out on top. With that, Ren, I'll turn it back to you, and I think we have time for some questions.
Thanks, Lisa. So on your chat sidebar, kind of where the poll was, there should be a message area. So if anybody has questions, don't hesitate to submit those there. As there is one that I wanted to ask of Lisa, as folks are typing in their questions, and that is, how can providers alleviate fears of safety when coming in office? So you had mentioned, obviously, at the height of the crisis, which we're just barely emerging, there were a lot of fears relative to safety in office. As folks start to deal with that pent-up demand, how could we, assure patients that they're safe?
I think that patients need to be made aware of the extremes you're going to in order to sanitize and cleanse the area. They want to know this. It's very similar to, and as you can imagine, as a consultant, I travel a lot. It's daily. I get the messages from the hotels, messages from the restaurant. This is what we are doing. And they're very explicit in explaining how they're cleaning and how that has completely changed in sanitizing. And the use of disinfectants. How are you using them? How are you going to keep patients separated physically? How are they? This is another big one. Patients are very worried about having to touch, just like in a hotel, how to touch a surface and a door. And so what are you going to have in place? Are you going to keep doors open so that patients don't have to touch them? How often are you going to clean them in case someone touches them? Are they going to have to sit in a waiting room with someone else, or are they going to be, like I said, summoned when they're ready to take you and you're ushered right to an exam room? There seems to be an unending appetite from patients wanting to know this. They are fearful. They've been in their houses for a long time. And so I think, Ren, to answer that question, is you just have to keep assuring them, but tell them what you're doing. And don't think that you're giving them too much detail. They want the detail.
And I think that also touches on the piece that you were talking about relative to communication. So what I'm hearing is, don't hesitate to over communicate.
Oh, not at all. No, you could say over and over again, you need to keep assuring them.
Yeah, we got another one here about do you have an opinion on how aggressive providers should be when collecting patient copay balances per current regs while balancing rebuilding the trust and potential remote registration? That's a great question. I've got some thoughts, but I don't know, Tom or Lisa, do you have some thoughts on that?
Again, I think this is where some of that regulatory flexibility has come in, and again, understanding that these are unusual sets of circumstances, that nobody should be denied testing or other types of things. I think that you don't have to be, as long as the emergency order is in place, as aggressive on that.
To collections activity, I do know a number of my clients have temporarily halted collections activity for balance billing balances, and even things like co-pays that were billed, not instead of being collected at the time of service, a billed co-pay, those are likely to resume, at least reminder activity on as the economy starts back up. I think it's as yet TBD on, balance billing from a procedure pre-COVID, as to whether or not the institutions will continue that collections activity or just take on, more bad debts. But, time will tell, I think, on that one. And as far as the remote registration piece of your question, I did hear of an organization. It's not one of my clients, but I thought this was excellent. It was a very streamlined remote registration process for pre-procedure that did include electronic collection of any amount due that was required. Say let's say there's a co-insurance. Or there's a payment upfront of pre claims that is required as a deposit, for example, and so that was all handled electronically via electronic intake, and then that was settled before the patient arrived for registration. So I have heard of some organizations being a bit innovative in that sense. I think we're at time, unfortunately. Don't hesitate to still type in a question if you have one in the next minute or so. We will answer any questions written in as we send out both the slides that we just covered, as well as some resources that might be helpful as your organizations look to reopen. So I want to thank everyone for their time today. We really appreciate you joining us, and we hope you got some valuable information out of our session. Have a great rest of your Thursday.